Hi everyone, I'm Jonna. I'm going to be the moderator today for the webinar. I just wanted to point out a couple quick features. There's actually a questions pane in the GoToWebinar panel. So if you have questions throughout today's discussion, Dr. Invergo will take some time at the end and make sure she can answer those questions for you. I'd like to introduce Dr. Alyssa Invergo to present to us about myopia and management in children.
Hi everyone, I'm Dr. Alyssa Invergo, and today we're going to talk about myopia and more specifically myopia management in children. So I grew up in a small town about 40 miles south of Chicago. I did my undergraduate degree at Ole Miss. I went to optometry school at Southern College of Optometry. Following that, I completed a cornea and contact lens residency at Pacific University. And now I'm an optometrist with Drs. Campbell, Cunningham, Taylor, and Haun. So let's start off with what is myopia. Myopia is commonly referred to as nearsightedness. So this is someone who can't see well in the distance without glasses, but they can see pretty good up close. So as you can see here, myopia ranges from mild to moderate to high. How prevalent is myopia? Well, 1 in 4 parents in the US have a child with myopia. That's over 14 million kids alone. And myopia has more than doubled from the 1990s to the 2010s. By 2050, it's estimated that 50% of the world's population will become myopic. So myopia is increasing at an alarming rate. So how does a normal eye compare to a myopic eye? So if we look at this normal eye, if we look at the front part of the eye, I'm not sure why my mouse isn't showing. Let's see, there it is. Okay, so the front part of the eye here, this is what you see when you look at someone's eye. This is where a light enters. So as this distance light enters the eye, it focuses to a single point on the retina. When light focuses to a point on the retina, the eye can see clearly. Now, if we look at that myopic eye, as this distance light enters the eye, it focuses to a point in front of the retina, so that the light that's actually reaching the retina is very scattered and this eye sees a blurred image. Okay, so the most obvious difference between these two eyes is that the myopic eye is actually longer than the normal eye, and this elongating of the eye stretches all of these ocular tissues. So we like to track the length of the eye with myopic eyes, and we like to refer to this as the axial length. So if you hear me talk about axial length or axial elongation, this is what we're talking about here. And that is measured from the front of the cornea to the back of the retina. So let's talk about a process called emmetropization. And emmetropia is someone that, or an emmetropia is someone that doesn't have a refractive error. So these patients have normal eyes or they see clearly without glasses. So emmetropization describes the process of the developing eye after birth. So most children are not born myopic. These children are born fairly hyperopic, or the common term for that is farsighted. So patients or children are born hyperopic, and their hyperopia gradually decreases as they grow to the point where they reach emmetropia in early adolescence. So the eye is trying to grow in a way that the refractive power matches the axial length of the eye so that no glasses are needed. But something goes wrong during this process and myopia develops. When myopia develops, it keeps elongating, the eye keeps elongating because it doesn't get the proper growth stop signal. So this is a really good chart to look at. And one point of reference is to evaluate a kid at 6 years old. A 6-year-old should have at least 3/4 of a diopter of hyperopia, and if they have less than that, they're more at risk for becoming myopic. So what is concerning about an elongated eye? Well, the longer the eye you have, the more increased risk of these serious sight-threatening conditions. So as you can see on this chart, the higher degrees of myopia is associated with an increased risk of these diseases. So myopic maculopathy is really similar to macular degeneration, but this doesn't result as a function of age. It results because the eye is too long. Retinal detachments, that can cause permanent vision loss if it's not caught soon enough. And then PSC cataracts can reduce your vision, and glaucoma can cause permanent vision loss as well. So the lower the degree of myopia, the lower the risk of these conditions. But my child can just wear glasses and or get LASIK when they're old enough. We hear this all the time. And yes, your child can wear glasses and get LASIK and they will see clearer. But all glasses do is shift the focal point to land on the retina. So now you're shifting light to land on your already elongated retina. And then LASIK, what LASIK does, it just eliminates the need for glasses. It reshapes the cornea so that light lands on your already elongated retina. So this doesn't change the shape of the eye at all. Your eye is still stretched. You're still at risk for all of these serious sight-threatening conditions that we just talked about. So what factors play a role in myopia development? Well, there's genetic factors and there's lifestyle factors. So if both parents are myopic, you have a 50% chance that the kid's going to be myopic. Just one parent's myopic, there's a 33% chance. And if neither parent's myopic, there's still a 25% chance the kid's going to be myopic. Now, our lifestyle has changed a lot over the past few decades as well. So lower levels of outdoor activity have been correlated with an earlier onset of myopia. And then prolonged near tasks and lower light levels have also been correlated with the development of myopia. So what is myopia management? Myopia management is a prescribed treatment program that aims to slow axial elongation and myopia progression. So this is the shift from simply correcting myopia, correcting your child's vision with glasses, like we've been doing the past few hundred years, and just watching their vision get worse year after year, to trying to manage their myopia with specific treatment options that have been proven to slow the rate of progression. So why are we doing this? The lower the axial elongation, the lower the risk of pathology later in life. That's the main reason we're doing this. So lower levels of myopia have some added benefits as well. You're going to have better uncorrected vision. You're going to be a better LASIK candidate. Sometimes if your prescription's too high, you are not a candidate for LASIK. You're going to have more options for contact lenses, and your glasses are going to be more attractive. They're not going to be as thick. They're not going to be as heavy. They're going to be more wearable. So ideally, myopia management, you would like to implement a myopia management treatment option as soon as your child develops myopia. You don't want to wait for them to progress. So you want to intervene early. So why does each diopter matter? This was a paper written by Dr. Mark Bullimore in 2019. It was a great paper, and I took away two statistics that I was really impressed by. A 1 diopter reduction in myopia reduces the risk of myopic maculopathy by 40%, and consequently, a 1 diopter increase in myopia is correlated with an increased risk of myopic maculopathy by 67%. So again, this isn't something you want to wait for your child to progress the next year and then consider myopia management. You want to put your child in a myopia management treatment option as soon as they become myopic, and ideally you'd like them to continue that treatment option throughout their developing years into maybe the early 20s. So how does myopia management work? How does this work? The main theory that's widely accepted is this theory of myopic defocus. So let's try to go through this and explain what myopic defocus is. So if we start with that uncorrected myope, we look at how the center distance light ray enters the eye. It enters the eye and it focuses to a point in front of the retina. So this child is myopic and they see blurry in the distance. Now, if we look at the peripheral light rays, how those enter the eye, we see that those light rays start to enter the eye and fall behind the retina. When light falls behind the retina, we call that hyperopic. So this patient has a hyperopic defocus in their peripheral retina. And hyperopic defocus has been correlated with axial elongation and myopic progression. So let's take that uncorrected myope and let's put them in a traditional correction treatment option. So let's put them in single vision glasses. Now as distance light enters that eye, it focuses to a point on the retina. So now this eye can see clearly. They're wearing their glasses. If we look at those peripheral light rays, though, we also see that these light rays focus behind the retina in the periphery, creating hyperopic defocus. Again, hyperopic defocus is what's correlated with axial elongation with myopic progression. So now let's take that uncorrected myope, and let's put them in a myopia management treatment option. So let's put them in one of these options that are aimed to slow axial elongation. So now as distance light enters the eye, it focuses to a single point on the retina, and the light that enters in the eye in the periphery lands in front of the retina. This creates this myopic defocus image shell, and that's what's correlated with the slowing of axial elongation. So most of our myopia management treatment options are going to aim to create this myopic defocus on the retina. So let's talk about some of those options. So these are the options that are available to us, and we'll go through some of these. I'm not going to go in depth with the spectacle options because those are not available in the US yet. However, I do feel like those are going to be coming soon, so keep your eye out for those options. Let's go through the first treatment option we're going to talk about. This is the MySight lens. This is the only FDA approved treatment option for myopia management, and the FDA approval was for initiation of treatment between 8 and 12 years of age. This doesn't mean that you can only put children between 8 and 12 years of age into this lens. This is just what they got their FDA approval for through their study. So what is this lens? This is a daily disposable soft contact lens. So this is a soft contact lens that you put on in the morning and you throw it out at the end of the day, okay? And it has a dual focus lens design, meaning it does two things. This lens will, one, correct your vision so that the patient will see clearly, and then two, it'll create this myopia control effect by creating this myopic defocus on the retina, okay? So these are the powers that they're available in. I do think they are expanding the powers, but let's go through some of their data from their study. They had a 3-year double-masked randomized clinical trial, and they looked at patients between 8 and 12 years of age, and they followed them for 3 years. So the treatment group was the MySight 1-day group, and then the control group was a single vision distance contact lens. So the MySight group, axial elongation slowed by 52% across all ages. And the MySight group also had a slowing of refractive error by 59% across all ages. And 41% of those eyes had no progression at all over the 3 years. So really impressive data there. These graphs are the 3-year data. They've since released 6-year data. I don't have the graphs up, but one of the really impressive statistics was that 23% of the eyes progressed less than a quarter diopter over 6 years. So really impressive data coming out of that MySight study. So I've got a video I'm going to show here. All right, so that's the MySight lens. Go to the next slide. So this is a great treatment option for myopia management, but let's say that your child doesn't fall within that parameter range. There are some other options as far as soft contact lenses that have shown really good efficacy for myopia management. These lenses are already on the market. They have a specific center distance design to it, so it creates that myopic defocus on the retina. However, many of these lenses aren't daily disposables, so ideally the MySight lens is my preferred choice if your child's a good candidate. So let's go through some of the data though from those other soft multifocals that are on the market. So this is the Blink study that was done, and the Blink study looked at 2 different powers of these multifocals, and it compared it to a single vision contact lens. And it had the patients wear this for 3 years, and they showed a significant slowing of axon elongation and myopia progression with that higher add power lens. And again, this is a lens that's already on the market, so this is a really great option as well for myopia management. Now let's move on to orthokeratology, or ortho-K. This is one of my favorite treatment options for myopia management. So what is ortho-K? So orthokeratology is the temporary reshaping of the cornea using a reverse geometry GP lens that's worn nightly to accomplish clear, uncorrected vision throughout the day. So what does that mean? So you wear this lens at night while you sleep, and you wake up in the morning, you take the lens off, and you can see throughout the day without anything, without glasses, without contact lenses during the day. This is similar to wearing braces for your teeth. This is like braces for your eyes. So this is a reversible process. It takes time to get the reshaping effect. Sometimes it can take 1 to 2 weeks until your vision's fully corrected and that it lasts all day. Maybe the first day you wear them, maybe you can see pretty well for a couple hours and then it slowly starts to fade off. But with each day that you wear them, you'll have that effect last longer and longer until you're fully corrected. So this is completely reversible. If you stop wearing the lenses, your cornea is going to go back to the same shape it was. So this has been around for a really long time. It's been around since the 1960s. It got FDA approved for correcting myopia in 1994, but it's not received widespread FDA approval for myopia management. There is one lens that just got FDA approved for myopia management, but I don't think it's hit the market yet. But many people have been using this for myopia management for many years. So this is kind of what the contact lens looks like on the eye, and this has a fluorescein dye in it, but it has a very unique pattern to it that allows for that reshaping effect to occur. So that this lens does 2 things. It corrects your distance vision, and it also provides that myopia control effect. And it does so allowing you to be free of glasses and contact lenses throughout the day, which is really great. So let's show this other video that kind of explains what I just explained. So that is orthokeratology. Let's go through. So as she talked about, this very specific shape of the lens creates this hydraulic forces that reshapes the corneal epithelium. So it creates a negative pull force and a positive push force. This lens is not physically mashing on the eye. There's always a thin tear layer between the eye and the lens, and that's why this effect is gradual and it takes time for it to happen. So this is just some corneal tissue. This just is illustrating that it happens at the layer of the corneal epithelium. So the epithelium is the outermost layer of the cornea. It's stained with this darker purple color here. So as you can see, this is before orthokeratology and this is after orthokeratology. So the fluid is redistributed through gap junctions in the corneal epithelium to get this effect. So who's a good candidate for Ortho-K? Ideally, you have to be evaluated to see if you are a good candidate. You can't have too high of a prescription. Your cornea needs to be pretty regularly shaped, and you need to make sure you have a regular sleep schedule. So for children, this usually isn't an issue, but for adults, and this is a good point, that adults can wear orthokeratology too. It's a great treatment option for myopia. It's especially great for people who are really active, such as swimmers or boxers, people who can't wear their contact lenses when they do those certain activities. It's great for people who get dryness with their soft contact lenses. But you don't want to wear orthokeratology if maybe you shift back and forth between the night shift and the day shift for work. You really need to have a regular sleep schedule. And ultimately, your corneal shape can limit your success. Occasionally, we've gotten really good with customizing these lenses. So many times we can get a good fit, but sometimes certain corneal shapes just don't allow for a good centered lens. There are some contraindications, so you can't have any corneal pathology, and you definitely cannot be a keratoconus patient. So best way to determine if you're a candidate is just to come have us evaluate you. So is orthokeratology safe? This is the #1 question I get asked. Orthokeratology is safe. Many people have concerns because this is a lens that you sleep in, and you hear eye doctors tell you all the time, don't sleep in your contact lenses. But many of the times we're telling you not to sleep in your contact lenses with soft contact lenses. Soft contact lenses kind of act like sponges, and they soak up all the bacteria in their environment, and then you sleep in that lens, and then you wear it all day the next day, and you sleep in it again. And those aren't how those lenses were designed to be worn. So the rate of infection is much higher with those than with this specialized, custom, rigid lens that you only sleep in for 8 hours and you take it out and clean it every night. So it's important to note that all contact lens wear increases the risk of microbial keratitis or a corneal ulcer. This is the most commonly referenced study by Dr. Mark Bullimore in 2013. This study looked at adults and children wearing orthokeratology, and it came up with an overall estimated incidence of 7.7 per 10,000 patient years. So what does that mean? So if 10,000 patients wore this lens for a year, 7 or 8 of them would have a corneal ulcer. And in this study, there were only 2 cases of microbial keratitis, and neither of them lost any vision. So orthokeratology is very safe, especially if you're very compliant with your care, if you're cleaning the lens as well. It has a very similar safety profile to that of someone who wears a daily wear soft contact lens. So someone who wears their contact lenses during the day and they take them out at night. So let's go through some of the research with orthokeratology. So this is the Romeo study. Dr. Pauline Cho did this study in 2012. It was a single-masked randomized clinical trial. The reason it's single-masked and not double-masked is just because of the unique characteristics of Ortho-K. The examiners are going to know which group is Ortho-K and which group is coming in wearing glasses. But this research had really good control. It looked at patients wearing orthokeratology and compared them to single vision glasses, and it followed them for 2 years. And the orthokeratology group slowed axial elongation by 43% compared to the control group, which was single vision glasses. So really good control here with orthokeratology. So let's go through some of the pros and cons. So pros, it corrects your vision and it gives you a myopia management control signal. So this does 2 things. It allows you to be free of glasses and contact lenses throughout the day. You don't need to spend money on glasses every year because you won't need glasses. This effect works even when you're not wearing the lens. The lenses stay at home, which can be really desirable for parents if they want to be more in control of the lens, if they don't want to have to worry about their kid losing their glasses or contact lenses on the playground, at school. So it gives you a little more control. Again, it works when you're not wearing it. So this is a really unique treatment option that's really desirable for a lot of people, just to give you that freedom of glasses and contact lenses. And I, as a practitioner, have better control of the parameters if I need to adjust the lens. One of the reasons why this is my favorite treatment option for myopia management is that I can completely customize the fit, I can customize the vision, versus some of those other treatment options where it's a one size fits all treatment option that comes out of a box. Those are still great treatment options, but I can really customize this one to better suit your child's needs. And then on the con sides, this is a more challenging fitting process. It's a longer process. Children may have to be out of school a bit more in the first year for appointments. Parents might have to take more time off work to bring them in. Vision's not ideal during the corneal reshaping process. So again, that can take a couple weeks to get right. And you might need to order another lens to get an appropriate fit. You may need to have a washout period. So we call it a washout period if we discontinue the lenses and have you go a while without it to get maybe repeat baseline testing. This is pretty rare. I think I've only done this once, but if you do ever have to stop wearing the lenses, your vision's not going to be ideal when you're not wearing them. Induced higher order aberrations. So higher order aberrations kind of describe optical imperfections that you see. So some people might notice halos around lights at night. Children usually don't notice this. Sometimes when they get older, they might notice it maybe when they're driving, but we can make a fit change when they get older to better eliminate those halos. So let's move on to the last treatment option we're going to talk about. This is one of my least favorite treatment options for myopia management, but it is still effective, and there are still some circumstances where this is a really great treatment option for the patient. So low dose atropine. So what is atropine? Atropine is an anticholinergic drug, meaning it works on the sympathetic system. It works on a variety of receptors in the eye. We use atropine in office to create a strong dilation and to knock out a patient's focusing system. That's the full strength atropine. The strength of atropine that's used for myopia management is a very low dose. It's compounded, and this is dosed nightly in both eyes. You just put one drop in before bed. This is unique in the fact that it doesn't create that myopic defocus on the retina like the other treatment options do. We're not exactly sure on the mechanism of action of how this works with myopia management, but there's been a lot of research. This has been around for a long time. So we just know that it is very effective. So there are some studies that I listed there. We're going to go through the LAMP study. That's the newest study. But again, this isn't my favorite treatment option because it doesn't correct your vision. Your child will still need glasses or contact lenses. And ideally, we want you to be in the treatment option for many years. And with this treatment option, a lot of people will start to forget to take it. And this does not work if you don't take it, unlike those other options. And if you're going to wear contact lenses, you might as well go into one of those other treatment options that we talked about. But still a good option for some people. So let's go through that LAMP study. So the LAMP study was divided into 2 phases. I've got the chart on the side here. This includes phase 1 and phase 2. Phase 1 was the first year. So this LAMP study looked at 3 different concentrations of atropine, and it compared it to a control. And it tracked them for a year, and it showed a concentration-dependent response, meaning that the 0.05% atropine had the largest effect in slowing myopia progression and axial elongation. So at that 1-year mark, the investigators didn't think it was ethical to keep that control group as a control group and watch them progress another year. So they offered the control group the treatment option of 0.05% atropine. And it showed a significant slowing of axial elongation and myopic progression. So that control group is that gray line here. And as you can see at that 1-year mark, they show a significant slowing and actually end up with a lower degree of myopia than the group that was on the 0.01% atropine. So basically the takeaway from this is that atropine is affected, and if you are going to choose between these concentrations, the 0.05% is the best option. So myopia management program schedule. So following your child's comprehensive eye exam, you would schedule your myopia management consultation if your child did end up becoming myopic. And at that consultation, we'll take various measurements. We'll assess your child's level of myopia. We'll measure the eye length. We'll measure that axial length. We'll go over all the different treatment options that we just reviewed here, and then a recommendation would be made. So not all of the treatment options have the same time commitment for the first year. Orthokeratology is hands down the most time intensive the first year. However, once you get the fit right, many years in the future, if you need to adjust the lenses, it's just a small change. Usually you only need to be seen twice a year, just to follow the axial length and make sure you're not progressing too much, but a little more time intensive the first year. So I think it's important to say that myopia management is now the standard of care. In April of 2021, the World Council of Optometry updated their guidelines advising myopia management as the standard of care. So again, this is a shift from correcting myopia the same way we've done for the past hundreds of years to really managing myopia and trying to lessen the overall degree that your child develops. We have so many treatment options that have proven to be effective, that there's no reason we shouldn't be educating patients and parents and recommending a myopia management treatment option. So feel free to schedule a myopia management consultation today. I see patients out of our Sevierville locations. I'm happy to see anybody, and I know a lot of our other doctors in our practice are happy to evaluate your child for myopia and talk to you about the different treatment options. Here are some of the references that I talked about today if you want to look at those. And thank you for your time. If there's any questions, I'm happy to answer.
Perfect. I just want to leave it open here to make sure anybody had a chance to ask questions here for a minute or two. I always hate to close it early, but I don't see anybody chatting right now, so I think that might be it. So thank you everyone for attending today, and we will be sending out the link to the actual presentation. So if you want to revisit this at all, watch your inbox, and we look forward to seeing you on future webinars. Thank you.
Thank you.